So here is a summary of our patient Carla, a 29-year-old woman who was left helpless as a result of poor medical management of her health in and out of the healthcare setting. Here's kind of a summary of what happened to her in her case. So first of all, lots of time is required for her dialysis appointments. They have an unflexible schedule, and the work and clinic schedules are pretty strict. At one of her appointments, poor blood flow was detected, and so an ultrasound was ordered. Carla then missed her ultrasound appointment, and at her next dialysis session, there was no blood flow found in her AV fistula, and there was a critical potassium, which then made her admitted to the hospital. On the day of her discharge, there was a lack of education on new medications and lifestyle changes, and a nutritionist could not be met with. Carla was supposed to be having weekly INR checks, but this was also missed by her, and the dialysis center was unaware that these checks needed to be happening. A month later, Carla notices some tingling in her face. She doesn't feel well, but she waits 3 days before going to the ER. When she does go to the ED, when her exam is finally done by the doctor, she is then admitted to the med-surg floors again. On the floor, she had a change in neurostatus. This was missed. The next morning, when there was a CT finally ordered, she was sent to the OR for a subdural hematoma, and brings us up to where she is now residing in a long-term care facility. Now, throughout her story, there are some times when her care could have gone better, and in these next few slides we will go over these problems and errors. So the first category is time. So the dialysis schedule is during her work week, during her work hours, instead of on the weekends or something that could better fit her. These appointments can last anywhere from 3 to 5 hours. When she needed the weekly INR checks, that required more time out of her busy schedule. And then they scheduled an additional outpatient appointment for a nutritionalist based on what time worked for the nutritionalist and not for Carla. And the nurse didn't do this education before discharge. There was an excessive time lapse in reporting her change in neurologic status twice. There was a long wait time in ER, no triage was done, and formal care rounds on Carla were done later in the day. Next, in the problem category is lack of resources. So the ultrasound was ordered at the dialysis clinic, but the test could only be done at the hospital. There was no nutritionalist on the weekend, so that made discharge education a little harder. The electronic medical record is only used in major hospitals in the network, which leads me into the clinics use paper charting, so it's not linked even at all or online. The dialysis center has an electronic medical record, but like I said, it's not linked to Southwest Medical. And as for Carla, the only contact they had for her was a disconnected cell phone number and a mailing address. So lack of resource to get in touch with her. Next is inadequate knowledge of staff. The ED, only a glance exam was done by the physician. The nurse did not notify the doctor of her change in with her tingling in her face. The medical student, when he did rounds, did not report her status to anybody. The dialysis center was unaware of the INR order. so that was not being done. And even though these dialysis sessions are lengthy in time, the nurse there was unaware of the patient's situation, didn't know anything about her financial or home life. Her primary care provider was not aware of the weekly INR results or lack thereof. Next is a lack of patient education, and this includes that the patient, when she was discharged, was only given one copy of discharge instructions, which she then lost. The patient was educated alone. She had no support system, so her mother or friend had no clue what was going on or what was supposed to be going on. The nurse did not do any nutrition education for the patient, even though she knew that the nutritionist wouldn't be seen until Monday. The social worker assumed that the patient got her appointment info by mail and did not confirm. The patient was unaware of policies at the ultrasound clinic, such as the late policy, and not being able to fit her in. Which leads me into the last section of poor policies. So there was restricted visiting hours. So the family and support system did not have enough time or adequate time to visit with the patient and learn more about her case or even get some education from the staff. Like I said, the late policy Carla was unaware of, about how non-forgiving it was, and the receptionist was not being a patient advocate. No stroke alert was called on the med-surg unit when the tingling appeared. Handwritten orders is what the dialysis center used. Now, this didn't really cause any problems, but this could have in our case. There was no triage done in the ER. There was an INR of 5.3 that was not considered a critical value or called to the doctor. And there was no follow-up from the hospital to make sure that Carla was completing her discharge requirements as she should have. Which leads us into this fishbone diagram of basically all these problems that I just talked about and how they interrelate to her being admitted to a long-term care facility. So, for the communication aspect, there was miscommunication between the hospitalist and the dialysis center, and even Carla. Carla was unaware of certain things, such as the INR checks needed to be done weekly. Going down to personal responsibility, she did not follow her treatment plan. She ignored the symptoms of the tingling in her face, and even though she had a vague idea of the INR check, she did not advocate for herself, or even when she was at the ultrasound portion of the hospital and she was late, she did not stand up for herself to get that done. On the quality care section, there was a poor assessment done by the ED doctor and by the nurses on the med-surg floor. At the hospital I work at, if there would have been a change in status like the tingling, a stroke alert would have been called. There was poor patient education about her blood thinner. Again, where I work, if we give a blood thinner, we have to do education on the blood thinner and document it. This is in our policy. And the nurse and social worker should have thought ahead about her discharge planning and about the nutritionist not being available on weekends, so they should have had this done before she left or before the weekend. Going down to socioeconomic status, there was a lack of financial resources available to Carla, which means she had a lack of a reliable telephone and no reliable transportation. I feel as though the social worker and case manager should have found other alternative ways to get her to her appointments or do something else where would fit better for her situation. Next, under the time category, there was a long wait time for lab draws and a wait for them to be resulted. And then the CT did not get done until later as well. And finally, under the healthcare system, the dialysis center is not connected to the hospital, so the orders and other communication was missed. In the ultrasound clinic, there was a fear of punishment for letting Carla in, even though the patient really needed it. And no interoperability kind of goes back to the separate clinics and hospital not being tied all together, which inevitably led to Carla being admitted to a long-term care facility.